Ahmed Omar Abdelaziz is a professor of diagnostic and intervention radiology in Cairo University, and he's one of the nice colleagues that I'm very proud of being his friend. The talk of Dr. Omar Abdelaziz is the endovascular treatment of renal aneurysm. Please, Dr. Omar, thank you.
Good afternoon, everybody. I'll give a short talk on the endovascular interventions in case of renal artery aneurysms. There are relatively low incidence, about 1% of all aneurysms and 22 to 25% of visceral artery aneurysms. They are predominant in females with a female-to-male ratio 2:1. Risk factors include vascular dysplasias, atherosclerosis, vasculitis, infection, and lastly, iatrogenic and cold pseudoaneurysms. Patients may be detected accidentally or may complain from a flank or pain or loin pain. In case of rupture, they may complain of hematuria, and rupture may complain of hemorrhagic shock. Risk factors for rupture are pregnancy due to increase in the vascular flow, volume and flow, the mass effect of the gravid uterus, and hormonal changes affecting the vasculature of the renal arteries, diameter more than 20 millimeter, and rapid growth of the aneurysm on follow-up. Rupture is associated with a mortality rate of 10% in males and non-pregnant females, and increase to 35% in pregnancy, and lead to fetal death in 60% of cases. The indication of endovascular intervention in renal artery aneurysm include the aneurysm size more than 3 centimeter or less than 3 centimeter in the presence of some risk factors like hypertension in case of pregnancy, deterioration of the renal function, hematuria, flank pain, dissecting aneurysms, single kidney, thromboembolism or infarction, and lastly rupture of the aneurysm. Different endovascular techniques have been utilized in the management of renal artery aneurysm, and most of the techniques have been derived from the neurointervention due to high prevalence of the cerebral aneurysm more than the renal aneurysms. These techniques include the use of flow diverter stents, stent-assisted coiling, balloon-assisted coiling, simple coil packing, and inflow occlusion and coil trapping, and embolization with liquid embolic agents like hysteracryl and onyx. I skip a slide here. This is the classification of renal artery aneurysm. Morphologically, they are classified into saccular aneurysm, whether in the main renal artery or in the large segmental branches, or the type 2 aneurysm are aneurysm in the fusiform aneurysm, and type 3 aneurysms are an intrarenal interlobar aneurysms. We can see here the classification according to angiographic images to aneurysms in the main renal artery and aneurysms in the hilum of the kidney and interlobar aneurysms.
There's technical error in the video.
Treatment of type 1 aneurysm in the main renal artery includes selective embolization with coils. This is the most widely used technique indicated for aneurysm with a neck diameter less than 4 millimeters, and can be used for management of the 3 types of aneurysms. However, difficult to be used in cases of wide neck and complex aneurysms. Cover stents have also been utilized for isolation of the sac from the parent artery. It can be done in the main renal artery without the presence of any branches, because the stent graft would obscure those branches. Both variants have been used in 4 or 5 reports in literature with 100% success rate. Also, the Josten peripheral stent graft have been used in few reports. The Palma stents have been used, and one report used the autologous saphenous vein covered stent. While the management of type 2 renal artery aneurysm is more challenging due to the complex anatomy and the location of the aneurysm, wide neck aneurysms are those with the neck size more than 4 millimeter or aneurysm dome to neck ratio less than 1.5 to 2. There presents difficulty in embolization due to the instability of the coils after deployment. So different techniques can be used in type 2 aneurysm. First, we can use a multi-layered endoprothesis and flow diverter stents. The aim of these stents are to decrease the turbulent flow within the aneurysm sac and enhance the laminar flow within the parent artery because they have intertwined multi-layers in their structure, which allows slowing of the flow. Different slow diverters have been used for renal arteries in case reports. We have the pipeline device, the Silk, the Cardiatis, and the Surpass device. They all show 100% success rate. In this article, they also use Surpass stent to obscure the neck of the aneurysm, and they use then a balloon for remodeling. And the follow-up here shows complete isolation of the aneurysmal sac. The Cardiatis stent have been used in one report and did not show complete occlusion of the sac after 6-month follow-up, and the authors here had to use another stent, the Silk stent, inside this, the first one, to achieve total occlusion at 12-month follow-up. A Casper stent has been used only in one report in literature. It is designed for carotid artery stenting. They say that it decreases the distal embolization during stenting of the carotid arteries. The authors in this article have noticed some flow diverter effect of this stent and have used it. However, they injected onyx in the same procedure in the aneurysmal sac, so it's not purely flow diverting procedure. Other remodeling techniques have been used for wide neck aneurysm. We can use stent-assisted coiling, where a stent is inflated and covering the neck of the aneurysm, and through the mesh of the stent or from beside the stent, we can introduce a microcaster for embolization. And also a balloon can be temporarily inflated at the side of the aneurysm neck, and coiling can be performed safely. Stent-assisted coiling has been used in 2 or 3 reports. The commonly used is a solitaire stent, and it achieves good response. With we can see the markers of the solitaire stent on the right side here, the distal markers. A waffle cone technique has been used in some bifurcating aneurysms where the distal tip of the stent is introduced inside the aneurysmal sac, and then we start deployment of the coils. The stent would prevent the protrusion of the coils inside the branching arteries. It has been reported in one report in literature here with a very good packing and good outcome. In this article, the authors used the balloon, a compliant balloon here, to cover the neck of the aneurysm, and with good packing. This technique has been described in the presence of a branching a side branch from the base of the aneurysm, where this side branch can be occluded using coil. Then the aneurysmal sac can be coiled, and then the coil in the branching in the branch can be removed safely. In this wide neck aneurysm, the author here did not perform assisted coiling. It is wide neck at the bifurcation. They use what is called the 2-catheter technique. 2 catheters are introduced inside the aneurysmal sac, and and deployment of the coils occur at the same time, preventing some coil protrusion into the parent artery. However, in this case, I think assisted coiling would be more safe. I'll show you 2 of our cases of type 2 aneurysm. In this 42-year-old female, she had right lung pain. Ultrasound and CT showed mild hydroureter and hydronephrosis that would explain her pain, but we accidentally found 2 large aneurysms at the renal hilum with a wide neck. Here we put a solitaire stent inside the parent artery, and we start a coiling of the aneurysmal sac, the big and the small one. And this is a control angiography showing good packing of the aneurysm and complete nephrogram. A similar case, but a complication happened in this case. I will show you. This is a 40-year-old male, hypertensive, with accidentally discovered aneurysm at the renal hilum. It's more than 3 centimeters and it's an indication for intervention. This is the Dyna-CT and the conventional angiography. During deployment of the stent, we want to put in the stent to cover the neck of the aneurysm into the superior artery here, segmental artery. Unfortunately, the stent migrated inside the aneurysmal sac after detachment of the stent. We tried to snare the stent out, but we failed. So we pushed the whole stent to lie inside the aneurysmal sac, and then we used another solitaire stent and we continued the procedure. The stent that migrated hindered our coiling. However, it went fine, and we were able to coil the whole aneurysmal sac completely, and this is showing patent arteries and good nephrogram. The type 3 aneurysm are the distal intersegmental or interlobar arteries, are usually traumatic or inflammatory. Treatment of those cases usually by using liquid embolic agents or coil embolization. Sometimes we use particles. The aim is to occlude the parent artery or the feeding artery of the aneurysm, and we sacrifice the renal tissue distal to the, supplied by this artery, which usually is clinically silent and can be treated by post-embolization treatment. Commonly used liquid embolic agents are glue and onyx. For coil embolization, there are 3 techniques: either sac packing in case of true aneurysm, while in false aneurysm you can go to coil trapping, where coils are deployed distal and proximal to the aneurysmal sac. In flow occlusion, where coils are used to occlude the parent artery proximal to the aneurysm sac. It's to be noted that renal arteries are end-on arteries, so we can do proximal occlusion for the aneurysmal sac. It's not like the liver that we are afraid from backflow from collateral circulation. So in the renal arteries, we can just perform inflow occlusion. This patient had a pseudoaneurysm after nephrostomy with severe hematuria. We reached the feeding artery with a microcatheter, and we put pushable coils. And this is showing the small infarct induced by the coiling. Another patient with perinephric hematoma and hematuria post-biopsy. He was unstable with hemoglobin 5. We used glue in this patient. We can see here the glue in the aneurysm sac, and you can see some reflux of the glue in the main in the artery, and in some side branches unnecessary. So it was not perfect embolization. We sacrificed some branches. However, my advice and my teacher advised that in case of emergency and bleeding, we just don't want to be perfect. We don't have to get good images. We try to work fast. We choose the fastest technique. I think glue embolization is the fastest. It takes a few seconds. We don't have to be perfect sometimes in unstable patient. Another case, 2 years old boy, he had perinephric hematoma post-biopsy, and he was unstable. After performing angiogram of the renal angiogram, it was normal. So we performed flash aortography to search for accessories or any bleeder. We found an aneurysm arising, pseudoaneurysm arising from one of the lumbar arteries. It was very small. We could not cannulate it with a microcatheter for embolization, and we went directly percutaneous to the aneurysm, and we injected glue with cessation of bleeding. In case of AV fistula, is also renal AV fistula is also treated with liquid and coil embolization. I would say for large AV fistula, we have to take care for avoidance of migration of the embolic material to the pulmonary circulation. We have to properly choose the size of the coils to avoid coil migration, and we have to do some anchoring techniques to avoid this complication. Complications that have been reported after endovascular treatment of renal artery aneurysm are major complications like renal failure requiring dialysis, minor complications like puncture site infection, urinary tract infection, urinary retention, minor renal infarct, transient renal insufficiency. Reported postoperative complications are stent stenosis, renal artery thrombosis, and post-embolization syndrome. In conclusion, endovascular treatment of renal artery aneurysm proved to be feasible alternative to conventional surgery with low morbidity. A detailed study of the renal vasculature and aneurysm location determined the choice of the endovascular technique. Type 2 renal artery aneurysm and complex aneurysm can be successfully treated by flow diverters and remodeling techniques. Thank you.
Thank you, Dr. Omar, for this nice presentation. Again, we are honored to